Well, good morning, everyone. We're going to go ahead and get started. I want to first thank you for joining us from across Lancaster County for professional development opportunities that we're providing with the partnership that we've been able to establish with Penn Medicine, Lancaster General Health. And this has been supported by our county commissioners, and they've dedicated CARES funding for this collaborative partnership. And so we're really grateful today to have Dr. Jeffrey Martin with us. Dr. Martin is the chair of the Department of Family and Community Medicine with Penn Medicine LGH, as well as the medical director for Lancaster County's contact tracing program. So he's going to be with us today for a period of time going over COVID-19 101. And just for some housekeeping items, I want to share with all of our attendees, if you have questions as you're going through the presentation, as you're hearing Dr. Martin talk today, please feel free to post your questions in the chat box. At the end of the session, depending on how much time we have left, we will go back to the chat box, ask some of those questions, and then we'll take additional questions and we'll work to get some information out to all the school districts to be able to provide some additional answers. So with that, again, thank you for joining us for this county-wide opportunity. And Dr. Martin, I'll turn it over to you.
Great. Thanks, Mike. And I'm going to stop my video here in a little bit, but I just want to say thank you. We appreciate the partnership that the school districts have gone into with Penn Medicine LGH, and hopefully the presentation today will be helpful. And I'm particularly looking forward to hearing what kind of questions folks have. So just a little roadmap for the presentation. We're going to talk a little bit about what we know about the virus. We'll talk about how to prevent and treat those that have COVID-19. I'm going to talk a little bit about testing for COVID. We'll give you a current update about what's happening in Lancaster County, and then I'll give you an update about contact tracing. I am the medical director for the Lancaster County Contact Tracing Program, so I'll give you a little bit of an overview for that. I think it's important to remember that prior to February 2020, which is only 6 months ago, although it feels like decades ago, almost no one in our country had heard about, much less affected by, the current coronavirus pandemic that we find ourselves in. And I have to tell you that the learning curve for me has been very steep, and I'm sure it has for you, but we do gain better insight into the transmission, treatment, and prevention of COVID-19 pretty much every day. And I like to use the analogy that in the beginning, it was like driving a car through a dark tunnel without headlights at 100 miles per hour. In fact, I think I used that analogy during a surge planning meeting that we were having when we were expecting about 1,200 cases in the hospital at one time. So 6 months in, I feel like maybe the car has slowed down to about 70 miles an hour and we have at least one of our low beams on and we can just kind of barely begin to see that proverbial light at the end of the tunnel. So what I'm going to present today is our best scientific understanding about where we've been, where we're going, recognizing that there's still much that needs to be learned and understood from a scientific standpoint. And with the caveat that, I'm very proud to be a member of our Lancaster community and our LGH health system community that has come together as we continue this journey together. So a little bit about COVID-19. The virus is called SARS-CoV-2. It's very different than the 4 strains of human coronavirus that are circulating on a regular basis. The disease is COVID-19. So I kind of use those interchangeably, and I'll be mainly talking about COVID-19. This is the 3rd novel coronavirus in this century. You may remember in 2003, the SARS-CoV-1 outbreak, which came out of China. It was a bat reservoir that then went to a secondary animal, a civet cat, and then to humans. And then 2012, we had the Middle East respiratory syndrome, or the MERS virus, which started in bats and interestingly went to camels and then to humans, although we're not entirely sure where the SARS-CoV-2 came from, but again, most likely involved bats and then a intermediate animal, then onto humans, and there's debate about what that intermediate animal might have been. So what do we know so far about COVID? We know that the virus is spread most commonly by close contact. And the mitigation procedures that we put into place around trying to prevent the spread of transmission are directly linked to this mode of contact. It's important really to make the distinction between droplets and respiratory transmission. So COVID-19, unlike measles, that does not appear to infect people with very small particles that can linger in a room for a long time and travel more than 6 feet. And so that's why we have the 6 feet and 15-minute guidance around prevention. The most common symptoms are fever, cough, fatigue, and shortness of breath, but we continue to expand the number of symptoms, and CDC puts out new symptoms that we should be looking at on a fairly regular basis. Infectivity can occur up to 2 days prior to having symptoms. This is so-called pre-symptomatic spread. And it can also occur in persons who have never developed symptoms. This is the so-called asymptomatic spread. Although we think that the latter, asymptomatic spread, is thought to occur at a much lower rate than those who are symptomatic or pre-symptomatic. However, as evidenced, I think, in our nursing home population, where there was a lockdown of residents in the community early on in this pandemic, COVID was brought in there from the outside, likely from an asymptomatic staff member. So even though the chance of being infected from an asymptomatic carrier is low, it doesn't necessarily mean that depending on the potential affected population, that the effect would be small. It can also be large, as we notice in the nursing home population. So the risk of transmission depends on the type and duration of exposure. So that's where you get the 15 minutes and 6 feet of contact definition. So we know that the use of preventative measures like mask and hand washing and individual factors like the amount of virus that's present in the droplets that are being spread also plays into that risk. We know that infections increase with the closeness and duration of contact and have been found to be higher in the following settings. And these are all settings where mitigation measures were not used, or settings where people are in frequent contact with each other. So such as households, other congregate settings like cruise ships, shelters, nursing and personal care homes. And there have been cluster outbreaks that have been described in large family gatherings, choir groups, religious ceremonies, bars and restaurants, and public transportation. We don't think that indirect contact, like passing somebody on the street or at the local Lowe's or Home Depot, really presents much risk, and those are very, very low risk contacts and not likely to lead to infection. So it really needs to be close contact in high density situations. So the biggest major risk factor for severe disease is age. And the graph on the right actually shows you the differences in cases, the percent of the population, and the percent of hospitalizations. And clearly, as you go up in age, certainly above 50, you see the percent of hospitalizations go up dramatically. The second biggest factor for severe disease is some sort of underlying illness, like diabetes, emphysema, or someone who's immunosuppressed. It's hard to find a case fatality rate, which is something that we really don't know because we don't know everybody that's been infected with the virus. So we're using something as a proxy called crude mortality rates. The American Academy of Pediatrics just recently came out with a big study of this across the country. And we know that mortality rates are quite a bit lower in children. I'm sorry that I even have to talk about that. But we also know that children are also infected at lower rates. So the case counts in PA for children age 0 to 18 is about 276 versus those over the age of 18, which is about 922. So they're affected about a third less than adults. In fact, when I looked, I didn't even see that there was a death of a child in PA. There's been debate about that. But there hasn't been a death directly linked to COVID-19. And so the mortality rate in children, we could say, is 0% essentially. There's been some back and forth on that, however. But that doesn't mean that kids can't get quite sick, and also doesn't mean that they don't transmit the virus to others. They can. At LGH, this was published today in the paper as well, age 0 to 18. We've had 189 positives. Again, this is just LGH, not county data. We've had 3 hospitalizations of folks with COVID, but they were not hospitalized due to COVID. It was picked up on pre-procedure testing. And only one of those children had mild symptoms. We have not seen any cases that we know about of multi-system inflammatory syndrome, although Pennsylvania reports that there's been 25 cases of that since the beginning of the epidemic. So this is just a nice graph that kind of compares COVID-19 to other viruses that have occurred. And where COVID-19 is definitely more fatal than seasonal or regular flu. It's probably close to the Spanish flu epidemic in the early 1900s. But the good thing about COVID is that it's not as contagious as some viruses like measles. So measles, as I mentioned, can spread on very, very tiny droplets. Coronavirus appears to just spread on larger droplets, and that's why we know that a mask works very well. Measles, for instance, if someone has measles and leaves a room, someone else that enters that room up to 2 hours later can get measles because it's still floating around in the air. That does not appear to be happening with coronavirus. So there's something that's very important. It's called the R value. And that means that for each case of COVID, one person can infect up to 2 to 3 people. With measles, that R value is 10 to 15. So although this is more fatal, it's definitely less infectious than some of the other viruses that we're concerned about. So the prevention matches the known transmission of the virus. So masks are highly effective, but only if you wear them correctly. So a mask, it needs to cover completely the chin and the nose, and try not to have gaps on the sides. Hand washing works, physical distancing works, and disinfecting surfaces will remove the virus from surfaces, although we don't think that brushing up against contaminated surfaces and then entering that virus into a mucous membrane is at very high risk. That's a pretty low risk for actually getting infection, and there's probably a lot of reasons behind that, but most notably the amount of virus that might be entering your body at any one time. So we do think that COVID-19 is in large droplets. By large, I mean more than 5 microns. And we don't think that it's related to airborne transmission like measles, which is less than 5 microns. And you can see the difference on the slide between the width of a human hair and what 5 microns would be. So that's in general very good news. So how do you wear a mask correctly? So on this slide, there's only one person that's actually wearing a mask correctly, and it's the one down here in the bottom right. I see this all the time when I go into stores and when I visit other locations, and I'm constantly kind of making a motion to my mask that you should pull that up over your nose. Some people comply, some people don't. We know that masks work. A recent study, this came out in June of this year, showed that when epicenters introduced mandatory mask orders, the trajectory of the pandemic spread dropped dramatically. So we saw this happen in Italy, we saw this happen in New York City, and it appears that the mask wearing itself might have been even more important than other mitigation procedures such as social distancing and staying at home, although we do think that social distancing and mask wearing definitely need to go hand in hand to be most effective. I also want to just say that there's very few times when a child or an adult cannot wear a mask, and the CDC defines these as kids under the age of 2, children that are unconscious or incapacitated or unable to remove a mask without assistance. There may be some children with significant developmental disabilities or behavioral health disabilities, which makes it hard for them to wear a mask. And sometimes if you're in a situation where someone's hard of hearing, you may not want to remove your mask because they might need to read your lips in order to communicate. So asthma and other respiratory problems are not reasons to be exempt from wearing a mask. In fact, I think folks that do have asthma or some sort of underlying pulmonary issue, you definitely want to have a mask on them if they tolerate it. So our primary care providers here at LGH have been instructed not to issue mask exemptions except in very rare circumstances. So I think it's important to realize that most people can wear a mask. There may be anxiety related to it, but we really want to try to have as many people wearing a mask as frequently as possible. Face shields are not an appropriate substitute, but you can add a face shield to a mask for further protection, and that's actually what we're doing for all our clinical workers here in the hospital. Hand washing we know works. This has been around for more than a century. In 1846, Dr. Semmelweis noticed that doctors who wash their hands in a chlorine solution after leaving an autopsy and prior to delivering babies had a much lower incidence of infection on the maternity ward. And so you need to do it for 20 seconds. You can use hand sanitizer as well. If you sing happy birthday twice while you're washing your hands, that generally gets you up to 20 seconds. Social distancing works. Unfortunately, our social distancing recently here in Lancaster has been subpar compared to some of our surrounding counties. This actually was produced by the Children's Hospital Philadelphia using crowdsourcing data. And they looked at cell phone data for people entering non-essential businesses and found that Lancaster is really kind of lagging behind. I think that may be reflective of why we've had a slight uptick in cases here over the past several weeks. But there's definitely disparity between some of the surrounding counties and Lancaster County. It also may explain why Lancaster right now has more COVID cases in the hospital than other hospitals in the Penn system. So I think clear communication that social distancing remains important. Mask wearing and hand washing are all very important tools in the toolbox to prevent COVID. Treatment of COVID is generally supportive. Rest, fluids, and everything else we do for viral illnesses, most recover without significant problems. We do have treatments, new treatments for hospitalized patients, and you can look at those in the appendix. Part of treatment, I feel, is that you need to isolate if you are confirmed COVID positive and accept the advice from the Department of Health or the contact tracing program if you receive that. Studies are looking at treatments that may lessen symptoms such as melatonin and vitamin D, but we don't know yet. And also in the appendix are some updates on vaccines. So it's important to call your doctor if you have any concerns at all about prevention and treatment. So what do we do from a public health standpoint? So early on when the virus hit the US, it was all about containment. And we tried to stop the spread, which was initially in a nursing home in Seattle. The original case, I believe, was also Oregon. However, when community spread gets too great, you can't really contain. So that's where you have these mitigation efforts that are put into place, such as closing schools, stay-at-home orders, masking, universal masking, social distancing, and so forth. And once the community spread reaches a certain level, and we were indeed able to flatten the curve here in our county, but now we're going to have a plateau of kind of a smoldering low numbers of COVID. We need to increase some of our other public health efforts. And one of the biggest public health efforts is contact tracing. So without having an effective cure or a vaccine, we really have to identify new cases as quickly as possible. We have to identify the contacts of those cases. We need to continue to put out health messages that mitigation measures are important and critical to reducing the spread. So these are all still very important pieces of the puzzle for where we're at in the current pandemic. So contact tracing is a tried and true public health measure. It's been around for decades. We've used it for other circulating viruses and also for tuberculosis, as well as sexually transmitted diseases. And it's been shown to be quite an effective tool in preventing pandemic spread. Essentially, we call cases, we interview them, they identify their contacts, then we call the contacts, and we give them quarantine advice. We also link people to social, who have social barriers to appropriate areas, such as someone has food insecurity and can't stay in their home without leaving. We help triage that. Also, people that have behavioral health needs, we refer them to appropriate services as well. So we don't just tell someone to stay in your home, we help them stay in their home. So where are we currently? So this is just a graph of what's kind of gone on in Lancaster County since the beginning of the pandemic. And the yellow line is the 7-day moving average of positives. Early on, we saw a pretty steep curve. It's come down pretty dramatically as our testing infrastructure has ramped up. We're trying to keep the percent positive rate down around 5%. That tells us that we are testing enough people and that we're getting to the positives as soon as possible. This is just another look at it. This is a rolling 14-day sum. It shows where Lancaster is in relation to other counties in PA. Early on in the pandemic, our curve was closely tracked with the overall PA curve. Lancaster is the orange line here. PA in general average is the blue line. On June 29th, we became the worst county in the state, which was about, at that point, we were about double the average of PA. But it's come down nicely and we've rejoined the PA curve. We've had a little bit of an uptake here in the past couple weeks, but today's graph again shows us dropping down a bit. You can look at these two. This just compares how the cumulative number of cases look in comparison to the other counties in PA on the left. And on the right, it shows our number of cases versus other states. So Pennsylvania in general is doing quite a bit better and certainly much better than all these states that are listed here on the far right up above our average line. And one other point of reference is the early warning dashboard that the Department of Health puts out. And I think that's a nice one to look at. The top 3 metrics are related to cases. The bottom 3 metrics are related to hospitalizations. So the hospitalizations tend to lag behind cases by about 10 to 14 days, which is what you would expect. So it's not uncommon to see the top ones being down, but then hospitals being up. And next week, I hope to see all these arrows pointing downward if we continue our downward trajectory. So let's talk a little bit about testing quickly. In our community, testing times, or the time when someone is tested to when the test has resulted, is quite variable. And it's dependent on a lot of factors currently. There are a lot of big labs that are using different platforms that have varying volumes from not just Lancaster County, but other counties in our region. There have been issues related to the supply chain of swabs and reagents and cassettes that these lab platforms need to function. And it also depends somewhat on whether there's an electronic interface with both our contact tracing program and PA Department of Health. The problem is that when turnaround times are so variable, that affects our ability to reach out quickly. And this is just a graph that gives you a little visual representation of what happens if we can reach somebody instantaneously versus 24 hours versus 48 or 72 hours. Essentially, anything on this graph that's green is good, orange is bad. So you can see that basically at 72 hours, if we don't get a test back in 72 hours, then our ability to effectively contact trace goes down pretty dramatically. So we're trying to work on all these issues. We're working on turnaround times. We're working on trying to get electronic interfaces for all the labs that are doing testing into the contact tracing program. And we're really trying to shoot to try to reach out to contacts within 48 hours. If we can do that, I think we're going to continue to see a reduction in cases in Lancaster County. So far, we have reached out to about 1,500 contacts and given them advice. We're looking at the percentage of cases and also contacts that we are able to reach. It looks like we're doing pretty well. We'd like to get up to 80% of cases and contacts reached. The most common reason why we can't reach contacts or cases is that we can't reach them. They don't answer the phone, or the phone number that we have for them is not accurate. Lower on the reasons why we can't reach cases is that people refuse to participate. We feel like no one should be refusing to participate in the contact tracing program. We're only trying to provide advice to keep you, your family, and your community safe. We're not going to do anything nefarious with your data, and we're certainly not going to suggest that your pet is quarantined, which I saw in a YouTube video recently. So about tests. So there's several types of tests available. The most common test, and the one that we're using most here in Lancaster County, is the PCR test. That's the nasal swab. It looks for presence of the virus. It's quite sensitive. It can detect only 20 up to 20 or above viral RNA particles. It's so sensitive, in fact, that persons who are initially positive may remain positive for 6 weeks or even up to 3 to 4 months, is what we're finding out. But we don't think those people are infectious after the 10-day isolation period. So we don't recommend repeating people who've already had a positive test, because you're likely to have a false positives. These tests can also cause false negatives. So if someone is in the incubation period and not shedding virus, they will have a negative test, only to 2 or 3 up to 14 days later have COVID. And we've seen quite a bit of that as well. Antibody testing is something that people are familiar about. It looks for presence of antibodies. We are not doing a lot of antibody testing. Not many of the tests have been adequately studied to make clinical recommendations. And interestingly, antibodies develop in 50% of people by the 7th day of illness. So someone can develop antibodies and still be infectious. So it all depends on where you're at in the trajectory of the illness. Also, we know that 50% of persons revert to negative antibodies by 3 months, but we're not sure what that means in terms of their immunity. We think they may still have some immunity, even though the antibody tests go back to negative. So we're not using antibody tests as an immunity passport or a back to work pass. So because of the issues related to the capacity related to testing, we are not doing a lot of asymptomatic testing at this point. We don't recommend testing returning students, faculty, and staff. In fact, the CDC agrees with us. We don't test employees who are returning to work. So you don't need to have a test if you are going back to work. Now, if you are a contact of somebody, that may be a little bit different guidance, but in that situation, you would quarantine. We do want to eventually get to the point where we can prioritize some high-risk groups, and you can look in the appendix of this presentation to see what I'm referencing as high-risk groups, but we're not at that point yet where we can do that. Why don't we test everyone? Well, frankly, if we did, we would affect our testing capacity, and our turnaround times, which are now around 3 days, would shoot up to around 7 to 10 days. And at that point, contact tracing really becomes ineffective. So we're trying to manage not only the testing infrastructure, but also an environment in which contact tracing will work well within our community. So this is the final slide, or next to the final slide. So what have we learned so far? We know that COVID-19 primarily affects adults, with increasing age being the biggest risk factor, and secondarily, medical complexity. Children can get the virus, and they do get sick, but it's at a much lower rate of adults. And we, fortunately, in our community, haven't seen significant illness requiring hospitalization among children. Any pressure on the testing infrastructure will have consequences for the entire county. So we need to prioritize and be smart about who we decide to test. Vulnerable populations like nursing home residents and staff, personal care homes, those living or working in congregate settings or high density settings should take priority. And we're trying to get there once we can fix the overall capacity for testing. And finally, and I think most importantly, we are all linked as a community. What I do affects you, and what you do affects me. And I think that's a message that we need to continue to spread and get out to the rest of our county. So in conclusion, thanks again for letting me present. We are all working as diligently as we can to find answers to this novel virus that has been present for just over a few months. We will be able to have more information, I think, day by day, and hopefully answer some of the questions that schools have in terms of opening up. But I do think eventually we will get to the end of the tunnel with everyone's help. So thank you for being involved today, and I'm happy to take any questions.
Great, thank you, Dr. Martin. And again, to all of our attendees, if you have any questions, please feel free to drop them in the chat box. Dr. Martin, I'll start with just one here, and oh, one just came in. It says, I am a PCA for a first grader, personal care assistant for a first grader. I do not have social distancing while working with my student. Any suggestions on how to keep myself and my student safe and healthy?
Yeah, that's a great question. I think, there are going to be situations, certainly in schools, where physical distancing of 6 feet is not possible. In those situations, certainly wearing a mask, being cognizant about frequent hand washing, trying to see if the child can also have a mask is really going to be your best bet to prevent spread.
Thank you. And another question came up here. What's the best protection for students in choir?
Well, so, that's gotten a lot of press recently. I'm not exactly sure if choir is something that should be an activity. We certainly singing or expressive yelling, shouting can potentially spread more virus. I guess you could have everybody with mask and try to socially distance, but then you wouldn't really have a choir because everybody would be standing 6 feet apart. I've seen Zoom choirs. This is something that I think about at my own church as well, that something as joyful as singing together and it's such a great activity we haven't been able to do because there is concern that that is a potential way to spread droplets at a greater extent. When somebody coughs or sneezes or yells, you release about 3,000 droplets, which is why masks are so effective because they contain those within that person's mask. And so choir, that's going to have to be an individual decision, I think, with the school districts about whether or not that's an activity that they feel is safe enough to continue.
And Dr. Martin, you talked about this with regards to the face shield, and obviously the mask is the better priority. But the question then came in as a follow-up to the choir question: would it be better for students in a choir to wear a face shield?
Yeah, I mean, so the way we've done face shields and also the wraparound goggles are if you're in higher risk environments, and certainly a choir would be considered a higher risk environment, that if you have a mask and a face shield or a mask and or a goggle, that would help, to prevent infection. We're using both things now whenever we're in any clinical scenarios and even when we're at our workstation at a clinical place. I'm in my office in the med staff office now, so I'm not in my regular office where I see patients, but if I were there, I'd have a mask on, I'd have goggles on. So they're additive. One doesn't necessarily substitute for the other. So I think masks are generally considered primary and secondary if you're in a higher risk situation. Certainly if there may be splashing or yelling or spitting, that face shields are definitely something that can be added to that.
Great. And then one other question here. Any concerns with the mandated screenings that are required in schools with regards to height, weight, vision, et cetera, as long as we can keep the children at a safe socially distance?
Yeah, I think it would be a how do you move kids around issue. I think just kind of how we do grocery stores where you maintain the 6 feet distance, you step up to the scale, you get weighed, you get your height, and then you're off. And everybody has a mask on. That's probably a low risk intervention that happens. And probably wouldn't increase the risk of spread too much.
Great. And there is one here about playing instruments. I think that kind of connects back to the choir piece. I know there's a recommendation for bell covers to be on the instruments, especially the woodwind instruments. and also making sure that everyone's in the same direction. And so I know a lot of our music teachers in the county, there was a study that came out from the University of Colorado in conjunction with the Colorado medical community around that particular piece. And there's more information still coming, particularly in the area of music on that end.
Yeah, I haven't seen any of those studies. That's an interesting one. I mean, with brass instruments, I think the droplets kind of get stuck in the instrument. With woodwind instruments, that may happen. I'd have to look at the study and remember that a lot of these studies that show droplets traveling a lot further than 6 feet or being on surfaces for these very prolonged period of times, that doesn't necessarily transmit into infection between cases. Those kind of studies are a lot harder to do. So you really want to look at transmissibility studies. So yes, droplets may come out of a woodwind instrument, but have we seen outbreaks or definite infection related to that? That's a completely different story. The COVID virus does not like to be outside of the human body, and it starts to die off pretty rapidly. And there's a certain amount of virus in each droplet that you need in order to get infected. So I would take those studies that talk about, droplets lingering in the air for a long period of time, or, being transmitted in unusual ways, like, air conditioning is always brought up, that, yeah, there's a theoretical risk, but we haven't really seen, significant transmissibility studies that say that's a way that infection happens frequently.
I know you and I have talked about this one, but it is a question here. It says, wouldn't taking temperatures upon entering a school help prevent the spread of the virus?
Yeah, I think absolutely. I mean, that's what we do every day when we come into the hospital. So I badge in, thermal camera takes my temperature. I'm asked the questions that everybody's asked whenever they go into a healthcare facility about symptoms, about if I've been tested recently for COVID. And I think that's important because if someone happens to have a fever and they're not feeling terribly sick, that may be a person that you want to send back home and not bring into the school community. So I do think those measures work, and I do think they're prudent to do, depending on how you decide to do it. Not everybody's going to be able to do it with the fancy thermal screeners that we have here at the hospital. Self-symptom checking might be adequate, but I know people are looking at different ways of doing that.
Yeah, and I know here in the county, I believe all the school districts are asking parents and guardians to help with the symptom screening at home. And then if they can't, then contact the school nurses to work out a plan as to what that will look like with students coming into schools. There is a question here also, how long do you need to have the virus until you get a fever?
Well, that's a great question. The incubation period is anywhere from 2 to 14 days. So for people that are going to develop symptoms, typically they will develop symptoms within that time frame. Less than 2.5% of people, it appears, actually develop symptoms within 2 days. So and the average is about 5 to 6 days once you're infected. But that's only for people that are going to develop symptoms. For those obviously who remain asymptomatic, they're going to be asymptomatic. So, and fever is a pretty common symptom. So that definitely would be a telltale sign that, this could be COVID. Now, the other issue related to this is, we're heading into the fall and winter months, and there's a lot of other things out there that cause fever. And probably a lot of other things that are going to be more common than COVID. So we're going to recommend that in kids that have symptoms that they try to get to see their primary care provider in order to kind of figure this out. Sometimes as a family doctor, you can say, oh, this is strep throat, and test them for it. And then, give them the usual recommendation. You may see an ulcer on their tonsil, and you might think this is Coxsackie virus. So we need to use our medical expertise in order to triage some of these cases. If they don't come up with a good reason other than COVID, then maybe they should be tested, and then based on that test. But the point is, we have a lot of expertise in this county. We can give parents and kids advice about what to do, and we can also notify schools if we think that somebody shows up in our office with a fever that's pathognomonic for Coxsackie or strep throat, that they should, follow the usual recommendations that we give for that, and that it's not COVID.
And then one question here, and just want to watch our time to and be respectful of your time. There's a question about whether or not schools should reopen in Lancaster if the number of cases are not below the 10 per 100,000. And I know that Penn Medicine is not making recommendations for schools because that's our responsibility to collaborate with the Department of Health.
Yes.
So that would be more of a personal opinion on your end if you wish to go down that path.
Yeah, I would have to say I don't have the full data set. Penn Medicine LGH, we have the data surrounding the testing that we do, but we don't have the data set which looks at all the positives in Lancaster County. And really without that, I can't make any recommendations that would be meaningful. DOH does have that data set, and hopefully they will be responsive to folks in the county to share with us, because as you can all imagine, that an outbreak that's happening in Columbia School District might be very different than what's happening in Garden Spot. And so oftentimes countywide or statewide measures are imprecise. And so we're trying to work with DOH to get a higher level of data in which, school districts might be able to manage the question of opening or not. But for now, it's sort of the best advice that we have, and we're certainly going to follow, the DOH guidance on that.
And just for our viewers, so that you are aware, we have reached out to the Department of Health from a school district standpoint, trying to request the data based on our school attendance areas to help make better informed data decisions there. And then just, again, another question popped in from a custodial viewpoint, other than wearing a mask, any other recommendations for classrooms where it's not possible to be at least 6 feet apart? And because it would be difficult for the desks and chairs to be disinfected throughout the day with only one custodial person in the building. So any recommendations there? Again, I think it's leaning more towards what's on the surface.
Yeah, again, the surface itself, we don't see surfaces as being huge vectors of infection. I know there was quite a bit of concern about that earlier on. So, I mean, I think in terms of the disinfecting procedures, you're going to need to wear gloves. You're going to not want to touch your face with your gloves on. You want to remove those gloves, wash your hands before removing your mask so that you don't contaminate your mask. So there would be some procedures around PPE use and how do you put them on and take them off, and we'll be sharing that with the school districts as well, because we have quite a bit of experience around that on the healthcare side.
So then, and this will cut it off here with this question, just so we're almost at the 45-minute mark. So what happens if a student or teacher has a cough or sneeze because of an allergy? And people think that it's COVID.
Yeah, well, that can happen, and that's why we try to say, at least in terms of cough, a cough that's not beyond the normal cough. Somebody with asthma or somebody with allergies may have a chronic cough. My office mate over here has allergies and he coughs all day long, but I'm not worried that he has COVID because he's always been coughing all day long about that. Now, if he develops a fever or something on top of that, then I would be more concerned. So again, these are questions that I think are important to reach out to your primary care provider about, to talk about. They should be able to give you good advice. We're really trying to look at identifying true COVID cases as best we can, but not everybody that sneezes or coughs necessarily needs to be quarantined.
Great. Dr. Martin, I greatly appreciate your time. Thank you so much for offering your service to provide this information to our educators across the county. I want to thank all of our countywide colleagues who joined in today. We have other sessions coming up, and I hope you can continue to join these sessions and spread the word with your colleagues, because we're trying to make sure that everyone across the county is getting the information And again, we're very grateful for our partnership with Penn Medicine LGH and the support of our county commissioners. So Dr. Martin, thank you again.
Thank you.
Have a good day,
Everybody have a
everybody.
safe day.